Good morning all. Myself, Dr. Shubhangi. I'll be talking about malignant glaucoma. It is a rare form of secondary angle closure glaucoma where clinically we see that there is shallowing of both central as well as the peripheral anterior chamber with the patent peripheral iridotomies with the normal to elevated intraocular pressure. These conditions are usually unresponsive to miotics, or they even get aggravated with the use of the miotics, and they get relieved with the use of the cycloplegics. This condition is basically a diagnosis of exclusion. It is called by alternate names like ciliary block glaucoma, aqueous misdirection, direct lens block angle closure. There are three different clinical forms. The classical form is commonly seen after penetrating glaucoma surgeries, commonly those done for angle closure glaucomas. The non-phakic form can be seen after cataract surgeries, and miscellaneously it can also occur after other surgeries like pars plana vitrectomy, corneal eye drops. Moving on to pathogenesis, the exact underlying mechanism is not known, but there are different theories which have been put forward, like Schaffer and Hossens et al. Have stated an abnormal vitro-ciliary relationship where there is a posterior diversion of the aqueous, resulting in the accumulation of the aqueous behind a posterior vitreous detachment, which leads to forward movement of the lens and iris diaphragm, causing an angle closure picture. The Chandler et al. Stated that along with the pressure from the vitreous, there is an increased laxity of the lens zone what's present in these eyes. Whereas Quigley et al. Has stated that there is an altered vitreous permeabilities, and because of which the vitreous is not able to transmit the fluid through it at the same rate as the aqueous goes out through the trabecular meshwork. And so there is a pressure difference which occurs between the two compartments, leading to vitreous compression and forward movement of the iris lens diaphragm. In the classical form that we have seen, there is an overfiltration in the immediate post-op period, which leads to the shallowing of the anterior chamber and the anterior rotation of the ciliary body. We can see here in the picture, we can see that this is the normal flow of the aqueous in pseudophakic or aphakic eyes. Whereas in malignant glaucoma, there is an accumulation of the aqueous posteriorly, leading to the forward movement of the iris lens diaphragm. Coming to the clinical features and early symptoms, the patient can experience improvement in the near vision and the patient start experiencing the symptoms once the intraocular pressure rises, and then the patient can have complaint of pain and difficulty in vision. This condition is usually difficult to detect before the elevation of intraocular pressure, and in science we usually find that the intraocular pressures are raised. There is a shallow peripheral as well as central anterior chamber despite of a patent peripheral iridotomy. UBM can be used to identify, as we can see in this image, that the asterisk mark shows that there is an anterior rotation of the ciliary processes, which results in forward diversion of the aqueous flow. And we can see that there is a marked shallowing of the anterior chamber. This is the lens and the iris diaphragm, which is pushed anteriorly, and there is a severe flattening of the anterior chamber. The common differential diagnosis for malignant glaucoma includes a pupillary block glaucoma, choroidal detachment, and suprachoroidal hemorrhage. Moving on to management, the first is the medical therapy, which is commonly employed. The choice of drug is cycloplegics. And cycloplegics, they are commonly given to relax the iris lens diaphragm to make it move it backward. And along with this, anti-glaucoma medications are prescribed to reduce the intraocular pressure. Osmotic agents can also be given, which will help to reduce the diaphragm. Then laser, if medical therapy is usually given and waited for a period of 3 to 5 days, and in case if there is no improvement, we move on to the laser therapy or surgical therapy. Laser therapy, we commonly the procedures done on Nd:YAG laser capsulotomy and hyalotomy, and if no improvement found, we can move on to the surgical therapy. In phakic patients, the procedure of choice is cataract extraction with intraocular lens implantation, posterior capsulotomy, and anterior vitrectomy. In pseudophakic eye, and an IZHV procedure, irido-zonulo-harido vitrectomy, can be done through a pre-existing PI or through a pars plana route. Moving on, the management of the fellow eye or the eye other risk is important. Patient should be, and good informed consent should be taken before proceeding for any incision surgeries in the fellow eye, and miotics drops should be discontinued preoperatively. A prophylactic laser peripheral iridotomy can be done if there is a shallow anterior chamber in the fellow eye. Prolonged use of atropine should be done, and a careful watch should be taken once the atropine has been withdrawn. A prophylactic pars plana vitrectomy before phacoemulsification can be done in the high risk eye. These are my further references that you can use for reading. Thank you.